of the College of Nursing at the University of Manitoba. As a member of CASN's Research and Scholarship Committee, I'm delighted to welcome you to the January session of the 2019-2020 Lunch and Learn series. I'm sure many of us are familiar with the concept of the Lunch and Learn, where faculty members come together during the lunch hour to share with one another projects they're working on and to dialogue and discuss methodologies, successes, and challenges they're encountering in their work. This webinar series is intended to serve as an inspiration and a networking opportunity for participants, while recreating the collegial feel of the Lunch and Learn. This year, the theme of each Lunch and Learn session is highlighting one of CASN's national research priorities for nursing. Today, for this fourth session of the 2019-2020 series, the theme is Nursing Research Priority Number 4, Care of Older Adults Across Diverse Contexts. I'm very pleased to welcome and introduce our esteemed presenter for this session, Dr. Kathleen Hunter. Dr. Kathleen Hunter is a professor with the Faculty of Nursing at the University of Alberta, as well as a nurse practitioner with specialization in gerontological and continence nursing. In addition to teaching and research, she maintains a clinical practice at the Glenrose Continence Clinic. Her research interests include hospital care and transitions for older persons, the concepts of safety and harm as they relate to preventable functional loss for older persons in hospital, and lower urinary tract symptoms in older adults. Dr. Hunter is an active member of the International Continence Society and is currently serving on the scientific committee. In May of 2019, she was the co-chair for the 2019 Canadian Gerontological Nursing Association Biennial Conference. I'm really looking forward to Kathleen's presentation titled Care of Older Persons in Hospital, Nurse Knowledge and Learning Needs. Dr. Hunter will discuss her own, as well as other recent Canadian research on nurses' knowledge and learning needs regarding older person care in the hospital setting. A profile of older persons in hospital will be presented, and the potential harms they face, particularly preventable functional loss, that nurses have a role in mitigating. Implications for further research, continuing education, and health service delivery will be considered. Following Dr. Hunter's presentation, there'll be time for you to ask any questions that you may have, and we hope that we'll really engage in some interactive discussion. To submit your question or comment for Kathleen, please use the question and answer function on your screen. Once you finish typing your question or comment, please remember to click the send button. I'll now turn the session over to Dr. Hunter so we can begin. Thank you, Kathleen.
And thank you, Neetha. I am really delighted to come together in this virtual forum to talk about something that's really near and dear to my heart, which is hospital care for older people. I am a great believer in nursing. I think when we see good nursing, we can know the kinds of outcomes that can happen. And unfortunately, when nursing doesn't quite have the opportunity to meet the mark that we know nurses want to do, we know that has incredible effects on our patients' outcomes. And I don't think we see this anywhere quite so profoundly as when we're talking about older people. So this does coincide or speak to the CASN Research Priority number 4. And I just want to mention that I was at the CASN Graduate Forum in 2017 when the draft priorities were presented, and it's a wonderful document. But one of the things that I spoke to at that meeting is in that draft, the care of older people and the research that was needed to be done was all framed around long-term care. And I think this would be a mistake for us because we know that not all older people live in long-term care, and in fact it's a fairly small proportion. But older people use the healthcare system across diverse contexts. And so I spoke, and as did other people, and asked that this be considered to look across the healthcare system. And I was just delighted when the final priorities came out and we saw that. So I'm going to frame my talk around nurses and their knowledge and what their learning needs are, around this whole idea of safety and harm in the hospital. And within that, I'm going to talk a little bit, and perhaps we'll have some chance to chat at the end of my presentation about this idea of preventable functional loss and what the role of nurses is in mitigating the harm of this. I think it's a big role. We certainly look at some of the work I and colleagues have done in learning needs around care of older people in the hospital setting, and I hope you will participate in our virtual discussion around where we need to go next. So this is a little bit about me, and this is, I call it my program of research, coming from academia. This is what we need to articulate, and you can see in the core center of the work that I do. For me, it's all about clinical nursing care and clinical nursing care of older people. And those two darker circles are where my work has really concentrated in the last few years. And not surprisingly, because I'm also a continence nurse, one is in lower urinary tract symptoms in older people, but also my other big passion is around looking at geriatric syndromes, or what we now call frailty syndromes, as older persons transition in, out, and stay in acute care. And for me, these are very highly linked. Lower urinary tract symptoms incorporates incontinence, and incontinence is one of those classic geriatric or frailty syndromes. Brocklehurst, way back in the 1970s, identified geriatric syndromes as being immobility, incontinence, impaired cognition, instability, also falls as a part of that instability. So these are really, as a clinician, how I frame up my thinking. And when I see people with lower urinary tract symptoms, oftentimes those are playing a role, and the incontinence is linked to the cognition and is linked to the reason why they're falling, and is linked to mobility issues, so that it all comes together eventually and plays out in terms of what's happening to patients. So let's talk just a little bit, and I'm probably speaking to a lot of the converted, so this isn't new knowledge for you. But we are sitting currently just over 17% of our population being 65 and older, the arbitrary line of 65. In 2016, it was 16.9, with 2.2% 85 and older. And we're all very familiar with the idea that our proportion of older persons in our community, in our Canadian community, is going to rise, and it's expected to be about 20% in 2024. I think a key thing that happened for us as Canadians, or that we realized in that 2016 Canadian census, was that for the first time in our history, the proportion of older persons, so again, the arbitrary age 65 and older, was larger, slightly larger, but larger than the proportion of children. So, and this is borrowed from the CAI website, and this is talking about, I love the title of this, uncharted territory. We are, with this change in the demographics that's happening in Canada and in many countries around the world, it truly is uncharted territory. And one of the things that is going to be a part of this is here, over this 20-year period, 2017 to 2037, the age, or the group that are 75 and older, will double. So that proportion of people who are getting into a much older age group is going to become greater and greater. And that's going to have a lot of implications for our healthcare system and for our profession. Here's a little bit about older people in our Canadian hospitals. And again, the CAHI stats show us that in 2017-2018, 65 and over people accounted for 43% of hospital discharges. If we move that cutoff to 75 years of age and older, it's still a quarter, 26% of hospital discharges. And when we take a look at what are the reasons for people to have an inpatient visit to the hospital, number one is giving birth, obviously not something that is usually on my agenda with my work, but look at 2, 3, 4, and 5. The other top 5 reasons, 4 of the top 5 reasons are all reasons that affect older people disproportionately, because a lot of these are what we call diseases associated with aging: COPD and bronchitis, myocardial infarctions, pneumonias, and heart failure. I think it's also prudent for us to think about vulnerable groups who come into the hospital, and one of those groups are people who are living with dementia. And I was pleased to see that CAHI has taken a look at this. I've given you a link there. It's a really interesting work that they're putting out. And they've done some analysis looking at people who are living with dementia compared to people who do not have dementia, both groups of older people, and looked at what are the consequences of hospitalization for those people. Well, for people that live with dementia, they spend 2.5 hours longer in the emergency department. That's got to be pretty hard when you have dementia. People with dementia, compared to those that don't, have a hospitalization rate 65% higher. And they stay longer in the hospital. And they experience a higher rate of hospital harms. So why is this happening to this very vulnerable group of people? And what barriers do we face as nurses in providing safe care and preventing harm for them in the hospital? The Canadian Patient Safety Institute is a leader, and I would like to acknowledge their role in that way in healthcare safety. But when we look at their 4 priority areas, and I have those listed on the slide, they don't encompass the concept of functional loss for patients in hospital. And unfortunately, this is also not reported in our CAHI data here in Canada either. So the particular problem around this is that comes out of what we do keep track of, what we're able to keep track of from hospitals. And this often is data that can be abstracted from hospital databases and records. And these are things like admissions, discharges, length of stay, discharge diagnosis, infection rates. We do not, in this country, and I don't know of any country yet that is doing this, mandates that we look at patient pre-hospital or baseline function and their function at discharge. We don't routinely measure this. And as such, we don't have the comprehensive data on truly understanding functional loss when people are in hospital, in spite of numerous research studies which have demonstrated loss of mobility being common in hospitals because we're not mobilizing our patients. We see great cognitive decline associated with delirium, and there's a number of studies that show that that can persist for months post-discharge. And also new onset urinary incontinence, often being associated with the overuse of indwelling catheters and indiscriminate use of absorbent pads while people are in the hospital. Further complicating this is that how do we tease out what is preventable loss and what is not? What is a consequence, perhaps, of the stroke, and what is the consequence of not being able to address that patient's needs fully, and that we could have made a difference in terms of the function when they leave in the hospital? And I think it's a really complex problem. How are we going to measure this regularly? How are we going to tease that out, preventable from non-preventable functional loss? But I think we have to start to think about this, how we can do this. And then also that will lead us to be, I think, being able to value this idea of function more. So this is my belief. I think that the occurrence of avoidable functional loss, whether it's cognitive or physical losses, for older people when they come into the hospital is a hospital harm. And nurses have what I truly believe is a tremendous role to play in the prevention of such harm. This idea has been beautifully articulated in an article by Bale and Greelash, and I've given you the references at the end of this, and I'd encourage you to look at this article. They're Australian nurse researchers, and they talk about this in terms of failure to maintain preventable functional loss and failure to maintain, and why that is happening and what's happening with nursing, that we have a part of that, unfortunately. So bringing the lens of my research lens on this, and just going through some of the work that I have done over the last few years around this area. So I started with Belinda Park and Laurel Strain. Belinda Park was a nurse researcher, Laurel a gerontologist from the sociology discipline. We started to work on this idea of trying to improve care for older people in hospitals. And we called our program of research Older Adult Hospital Readiness, because we wanted to take a really proactive approach and say that we could empower people and their families to make this a better experience for people when they had to come into the hospital. Our work came from a social ecological perspective, and you'll see that as I go through a little bit about our findings, and also this idea around safety and prevention of hospital harm. That was really key to us right from the start. We all have to start somewhere where we're trying to bite off a piece of the research pie and trying to make a contribution to improving care. So we decided at first we would go with a vulnerable group, those living with dementia, and at that pointy end of the stick, the emergency department. So we called this coming to, being in, and leaving the emergency department, and that intake valve of the hospital. Our first study was looking at urban emergency departments, and we were very fortunate to get a CIHR Alzheimer grant for this money, or for this project. And there's the main publication off of this study. It was a qualitative study, and what we wanted to look at were what were the factors that facilitated or impeded what we termed safe transitional care. And safe transitional care was that sense that the patient and the family knew what was going on, that we attended to the plethora of care requirements, including those fundamental care needs as people move through the system. We had 2 emergency departments participate, and 10 older adult family caregiver dyads. So these were older adults who were living with dementia. They were at a moderate stage and were able to participate verbally in the interview process. We had 10 emergency department registered nurses, and we had 4 nurse practitioners as well from the hospital. These were all gerontological nurse practitioners who worked within the geriatric services, providing consultation down in the emergency departments of the hospitals. So what did we find? So the way we analyzed the data, we took the dyad data and used it as a driver, and then put that, sort of surrounded that with the data from our nurses and our nurse practitioner participants. And our overarching theme was the way it works. And it was all about how priorities get determined in the emergency department. The first one was being under triaged. So both our participant groups, the people living with dementia, our dyads and their family caregivers, as well as the nurses, really identified that oftentimes people are presenting in the emergency department, and the seriousness of their change sometimes doesn't get recognized. Now, I have to say, since we did this study, there's a lot more work coming out on this, and certainly the Canadian triage group has been trying to do some work on trying to really understand more fully the presentation of these complex people to the emergency department. But this being under triaged was a real issue for all of our participants. The participants, our dyads, talked a lot about having to wait, and also both groups talked about this time pressure and the lack of attention to what often kept being referred to as basic needs, the basic needs. And our last theme within that was looking at the relationships and the interactions and the feelings of being ignored or forgotten or just not important in this really busy environment. So I just picked off one quote from this study, and from one of our nurse participants who described, people with dementia in emergency departments being bypassed. Right? So, it's a busy shift. It's, the care needs. So something as simple as needing to go to the bathroom, a functional concern, it's just not a priority. From this research, we developed we called it our toolkit. We did continue our partnership with Alzheimer's Canada for this component, the KT component of our study. And we developed a series of tools that we hoped that people living with dementia and their caregivers could use to anticipate that there was a good chance at some point they were going to end up in the emergency department, how to prepare for that, and how to advocate and really empower themselves as a dyad when that came about. We had some additional money from Alzheimer's Canada that allowed us to do some caregiver focus groups, both in English and French. We did them out west as well as in Quebec, to gather some feedback on the feasibility of use of our communication tools. And we did do some adjustments of that. And so there's the article if you're interested in how we developed those tools. These are the tools. They are on the Alzheimer's Canada website, and I believe I gave you the link to that. And I was really pleased to see that in our bags when we were at the CGNA conference in Calgary, the Canadian Gerontological Nursing Conference in the spring, The Alzheimer's Canada has done another iteration of this and produced a really quite a lovely little just information booklet for people living with dementia and their caregivers about this idea of being ready, being prepared, and thinking ahead about how they can manage and speak for themselves in this busy world of the emergency department. We also developed a photo narrative journal that we did pilot with some nurses in the emergency department and looking at education and trying to sensitize them to what it's like to be an older person in the emergency department. So all of this work, you know, Belinda and I got thinking and stewing and doing all sorts of things. And we came up with this article, and we called it our polemic. We really wanted to sort of poke the tiger in the eye, critique the system. And it was all around this idea that caring for older people is common sense, because we heard that a lot. We heard that in some of our data from the emergency room study. Belinda and I had both been gero nurses for a very long time, and we heard that, well, you know, you don't need special knowledge to look after older people. It's just common sense, and the care aides can deal with that. So in this article about common sense, we talked about the myths of older people in the hospital system. And the first of those myths was that all older people in the hospital are the same. They all have the same care needs. And I think this is our tendency at some of the stigmatizing of age that we tend to do, that we see aging as something that's just, you know, sort of this homogeneous phenomena that occurs, where it's actually, we know that it's actually quite heterogeneous. We all age at different rates. We all have different experiences as older people. So when people come to the hospital, they're not all the same, and they don't have the same needs. And we identified 3 types of people who come into the hospital, older people that come into the hospital, those that are old and able. So they we don't worry about them. They're good. They fit in the hospital system. You come in, you have your surgery, you're able, you're out. We talked about the case of being old, being able, but being rendered disabled through processes in the hospital. And this is this idea of functional loss that really shouldn't occur while people are in the hospital. Those cascades that lead to disasters. And then the case of being old with an invisible vulnerability, not something that catches anybody's eye. And then a 4th group about being old and unable, those truly vulnerable people who come in already with great functional needs into the hospital, and how we have such difficulties serving them. Wrapped up in this, this was a polemic and a critique, we really saw this as a problem of the domination of the biomedical model in hospitals, an efficiency model. And this leads to us setting those priorities about what's important. And unfortunately, sometimes what happens, and maybe not just sometimes, but often, what's important is the biomedical issues, getting those meds up, getting people moving efficiently in, out, discharging them out of the system. And those other care needs, those ones we label as basic, become much less important and sometimes ignored. And our conclusion in this article is really that acute care nurses really need to have kind of almost like a dual expertise. They need to have an expertise in the area of their work, so the example being med-surg, but they also need to have the expertise in gerontological skills and knowledge as well, because this is their patient population. And get the next slide. Good. So sitting around having lunch one day, lots of good ideas come up at lunch. Belinda and Laurel and I were having lunch with Dorothy Forbes, and we were all here at the University of Alberta at the time. And we said, well, we've learned a lot doing our urban ED study, but no, I bet you it's really different in the rural setting. And Dorothy had had done a lot of work in the rural setting in terms of people living with dementia. And she said, yes, I think you're right. So we were, again, excited about this idea, and we're fortunate to get a CIHR Catalyst grant in order to take our work and try and replicate it in the rural area. So we really wanted to try to extend this idea of what hospital safety meant for this population, and that hospital safety needs to go beyond medication errors and fall incident reports, and to a better understanding of what's happening around this idea of functional loss as a harm. So again, a qualitative study, our social ecological lens was on, and here we had 12 healthcare professionals from 2 rural emergency departments in 2 different provinces participate in the study. And I'll just let you know that part of our protocol was to recruit older persons with dementia and their caregivers, as in our first study, but over 2 years we were not able to recruit. You can ask me more questions about that at the end if you'd like. So our study turned out to be a study only from the perspective of the healthcare professionals. However, it was an interesting find. We had 3 themes here, and again, it's the social ecological lens. So we saw or heard our participants talk about their physical environment, these issues within an emergency department, where this really was not, even in the rural areas, these little emergency departments, they're not designed for older people, for the needs of older people, to accommodate caregivers to be with them. The physical environment is very limiting for the healthcare professionals. The healthcare professionals also worked within a work environment that was had its own set of beliefs around what their role was within their community, within the healthcare system, what the general role of an emergency department was, and they really talked about this pressure to perform. So getting people in, getting people out, working, and they work very hard, but they're under an awful lot of pressure to do that. And then they spoke to the practice environment, and there was a great deal of acknowledgement of the importance and contribution of family here. And here we saw what we think were some of the really important things in terms of rural issues, that tight-knit community and some of the ways in which our participating healthcare professionals could work to try and support these older persons living with dementia when they come in, even though this is that high pressure, not very well designed environment for them, and how they worked with the family. They also talked about knowledge and processes, knowledge being that not all of them had, or them or their colleagues had the knowledge around this particular group of patients, understanding of dementia, and also the processes that they had to work under. This is a model we developed with this, and here you can see at the bottom, the healthcare professionals in these rural emergency departments were always trying to do this. They held the idea of safety as important, and they wanted to try to avoid harming these older people with dementia as they came into the emergency department. But it really was trying always to work with that balance of the environment, of the pressures to perform, and what they could pull forward to try and provide the best care they could, and working with the families. And when we talk about how they defined that idea of safety, well, that's really interesting. Here's a quote from this study, and she says, "We start to do terrible things like drugging or tying up their wrists to the rail to make sure they can't do their IV, which makes you feel awful, but it keeps them safe and where they're supposed to be, but it's not good nursing." So I think this quote shows this real tension. This was a nurse informant who said this real tension for the nurses that, and what is this safety? I'm trying to keep them safe. I'm using restraints to try and keep them safe, keep them here, but recognizing also that there's something wrong with this. This person just was not comfortable, but this was the care that had to be, that she felt she was pressured to provide. Now, my good friends Belinda and Laurel retired shortly after this, and I was really fortunate to have an opportunity to work with Sherri Dalke, who joined us here at the Faculty of Nursing, University of Alberta. And she and I both, again, shared a passion for this topic, and we started a partnership. And so the program of research that we've been building together, we call it InHosp. We're really focused on people both in acute care, and we've been doing some work on inpatient rehabilitation as well. And still, our focus is very much that safety versus harm, and also what we call the fundamentals of care, not basic care, but fundamentals of care that need to be provided by nurses. And if you want to read more about this idea of fundamentals of care, I would encourage you to have a look at the work of Kitson, who speaks quite eloquently to this. So, what are the projects we've done under this? We started working with one of the hospitals here, one of the larger hospitals here, on the medical units, inpatient medical units. We had a lot of support from the managers in this area, and wanted to know in this first study that we did together about what the nurses thought their educational needs were in terms of working with older people in the hospital. So this was a mixed method study this time. We had used both surveys and interviews. We had 22% of the nursing staff complete the surveys, and 11 participated in the interview portion of this. So when we had them fill out standardized tools about gerontological knowledge, the knowledge actually was pretty good. It could be there on paper. Moderately high overall scores. Also the quite good scores on patient-centered care measures as well. However, when we did the interviews and looked at the data from that, there was a bit of a different picture that emerged. So the knowledge was there on paper. However, the nurses really talked so much about older people in hospital and recognizing them as a vulnerable population. The types of clinical concerns that they had around these patients, and the need to work together as a team. And they identified their priority learning needs as a part of this. And the things that they identified were they wanted to know more about cognitive impairment, and particularly around responsive behaviors, use of chemical and physical restraints, how to have alternatives to those. They wanted to know more about continence, so I was happy about that, and also how they could get engaged in mobility and what it was about mobility that was so important. So the safety and harm implications of this work was that there was still this overuse of catheter restraints and concern around potentially harming the loss of function. And it was really tied to the nurse's workload. The intentions are good, but those fundamental needs just sometimes they don't get to them. They have trouble with them because their work is just so demanding. So there's a couple of quotes there. We're not going to take a lift for a patient, so you just have to be incontinent. These are struggles that nurses go through. Sherri and I, as well as one of our PhD students, Kelly Negron here at the U of A, wrote a paper on safety and harm as well. This was an integrative review because we wanted to know how hospital nurses, acute care nurses, particularly in med-surg areas, defined safety and harm for older people. And out of the 23 studies that we identified address safety and harm, most of those were around concerns around restraints. And it came through on the analysis of those articles on nursing perspectives that oftentimes nurses are using restraints, limiting mobility, because they have this conceptualization of safety. If they keep them tied up and they're not walking, then we can make them safe and they're not going to fall. And sometimes the consequences of falls were such that it was almost that it was an administrative or a policy pressure that forced them into this. They didn't want to have their patients fall, and so restraints were there. Going back to our work on the acute care units, we did go back. We did a 2-hour workshop for our acute medical nurses and healthcare aides on cognitive impairment and responsive behaviors. And some of the outcomes of that, or one of the things we measured in that as a part of that study, is we wanted to measure the context of care. And we were really interested in the context of care in terms of, all right, we're giving some education, but how do we need, how can we inform a thoughtful way forward in trying to support these nurses in trying to change the practice on the units? And so we used the Alberta Context Tool, which is a tool developed by Dr. Carol Estabrooks, and it looks at how easy it is or how difficult it is for nurses and other staff to put in place evidence-based practice, because we're really talking about evidence-based practice. We know that not mobilizing patients leads to further immobility and the consequences of that. So there's a lot of evidence with that. Results of this showed that the nurses were really they liked having the education. However, they could identify a lot of barriers, and looking at that context from this tool, which includes dimensions such as leadership, feedback, connections, resources that students have, and also, I think, interestingly enough, organizational slack, time to address trying to change the care. We found that some of the lowest things were that organizational slack and informal interactions and feedback that were areas that the nurses rated low, but areas that we could potentially look at in next studies. So our ongoing work, as I said, we did additional continence education intervention with this same group of nurses, and we're just writing a manuscript on that at the present time. We are working with an interprofessional group to take this work try and move it forward, and to look at how can we implement sustainable strategies for older persons in hospital, with the focus on maintaining function and that idea of safety and harm. And we're also doing some work on the inpatient rehabilitation units as well. And some of this is focused around continence and trying to restore and maintain continence in that group of patients. So implications, I see I love to talk, so running out of time. Implications. So I think that this idea of trying to maintain and restore function is not just something that we leave for post-hospital care. It's something that we have to be thinking about in hospital for vulnerable older people. And for me, it does wrap up around this idea of preventing unnecessary harm. I think we have to try to find ways to advocate to go beyond measuring these easy things like admissions and discharge, and saying, how do we measure function? How do we get an understanding of how well we're doing in that area in our hospitals in Canada? And how do we change practice? We need to be a part of that active collecting of information and being informed about our patients' baseline and how we address this within the care while they're in the hospital setting. We need to balance the biomedical efficiency model. Certainly, when those antibiotics are due, they have to get out. But we have to balance this with those more, and I put it in quotes, basic care needs. And we have to change the language from basic care needs to this idea that this is part of the fundamental care that needs to be provided to these patients. I think it's rich with implications for education and research. Sherri and I have joined with a number of other researchers, and we're doing work now in the area of undergraduate education in gerontological nursing and attitudes around caring for older people. I think there's probably also a rich area that we haven't touched that needs to be thought of is nurses already in practice. How do we reach out to them? How do we provide the education for them? How do we try to support them in changing care practices? And I think in our policy, moving to this idea that we need to start measuring function in hospital patients. I think that's going to help us really, truly value patient-centered care, not just pay lip service to it within this big biomedical efficiency model that we have. So I hope I left a few minutes in case people have some thoughts, or it doesn't have to be a question. It can certainly, I'm always interested to hear your feedback on the presentation, your ideas around functional loss, avoidable functional loss as a harm.
Well, thank you, Kathleen, for an excellent presentation and very thought-provoking. I certainly have lots of areas that I'd like to have further discussion with you on. And congratulations on your great research that you have been working on together with your colleagues.
Thank you.
So we have time for questions and comments and some discussion. We have received 2 comments already that will relate to you, but also invite others. If you have any other questions or comments that you'd like to engage in with Kathleen, please feel free to add those now to the chat box. and then we'll consider them together. So we had a comment from Ruth, who thought it would be great to interpret this with the use of a variable of staffing ratios. And you got into it a little bit, but you might want to comment further on that. As well as Krista, as another variable being the practice settings to explore.
Yeah, thank you. Those are important. One of the things, and I don't mean to imply that the care they provide is not important, but I think we are seeing a real change in staff ratios. We certainly are seeing more care aides in hospital settings, and I think we need to have a look at that. What I would hate to see is that this idea that we just relegate all this, stuff we label as basic care off to the care aides, and then as professional nurses dissociate ourselves from that. So I think looking at those changing staffing ratios, what does that mean? How is the work being distributed? And then, so what is the role? What is the role of the care aide? What is the role of the professional nurse in this? I think those are fabulous questions. And then the other question, the other comment was around, I'm just scrolling.
What's about the variable of practice settings?
In practice settings, yes. And that's part of what I didn't spend enough, you never have enough time to talk to all of this. But if you want to look at that article that I talked about in terms of the context of care, that's call it the feasibility of implementing education on older persons' care to practice on medical units, nurses' perceptions, and the influence of the practice context. The practice context is enormously important in this. When I go back to those studies in the emergency department, and this pressure that we call pressure to perform that the staff worked under, that's a contextual thing we need to think about if we're going to go in and we just say, oh, well, you should all be doing better for older people while they're here in the emergency department. No, we have to have a look at their world and what's going on in their environment. What is the context? What are the priorities? But not lose sight of these other, really fundamental components of our care, and how do we balance those? This idea of balance is, quite fascinating for me. How do we support nurses so they can do that balance? And yes, the context of where they practice, the policies, all of those things play a role.
And Josh is wondering if you have any reflections on what hospital staff have shared with you in terms of being aware of the magnitude of harm that can occur in hospitals, and if there's any disconnect between neglect of basic needs and how this actually affects older clients.
Wow, I've thought a lot about this, Josh. I think so. Again, if we go into the safety and harm literature, Dixon Woods and Herod, who used Dixon Woods theory, I think they kind of speak to this because nursing is really complex in these settings, and the nurses are there they see their 8 or 12-hour window with their group of patients. Then they're maybe away for a few days. They come on in a different shift. They may not see that, but other nurses come in. So we have all of these nursing players coming in back and forth, and they don't always see the outcomes in terms of the functional outcomes for their patients. And so that's a real issue. So Dixon Woods and Herod Dixon Woods called them tightly coupled errors, and Herod calls them loosely coupled errors. I like the loosely coupled errors, and she speaks to this. She did some work in emergency departments as well. This idea that when you don't see the consequences, so you're there, you're working, you get your shift done, you get your work done, but you don't see the consequences down the line of the care. And that includes ignoring those basic needs or not attending to them or not having the time to attend to them. It's very hard for nurses to get the big picture. And this is why I think we need to really try to make a way to measure these things so we can bring that back so the nurses can see that. Because nurses have to act as that big team all together. So complex, but just because it's complex, I don't think we should run away from it.
Yeah, and Josh is saying his experience as a emergency RN echoes exactly what you're saying. So Ruth is also saying that there's changes get made, such as through the elder-friendly hospital initiative, but it's difficult to sustain that kind of change. And how do we make it common practice? You might want to comment further about that.
Right. Yes. So yes, absolutely. Belinda was a huge leader, both nationally and in her home area, Victoria. And in our article, Common Sense, we talk about this problem because over the last 30 years we have seen programs come and go. So 1995, when I came back in as a gero nurse into the acute care environment, that was when the work around ACE units was just coming out. And so we see this rise and fall, and we've had iterations in different places of elder-friendly care, senior-friendly care, and Inouye's model. And sustainability is really difficult. I think it has to do with the players that are there. The commitment, I think it has to do with changing what we value within the healthcare system. And that was part of some of the underpinnings of the work that Belinda and I were doing together, and why we called it our older adults hospital readiness, because there's such pressure in our healthcare systems, in the acute care systems, to move people along, get them in and out. And I really think that we need the voice of the public to come in here. And we need to be a part of talking about this and getting people on board. And when we have the voice of the public that says, you know what, when our family members come to the hospital, we actually value this care. We value the fact that you've helped Mom be able to maintain her mobility, even though she was in the third time with her COPD. But we valued that function was maintained. I think we have work to do in terms of getting the public's understanding up with that, getting them excited about that, and then getting them to have the power to push, because there's nothing more powerful than the electorate, right? To set priorities.
Well, Kathleen, we just have a moment left, and so we're going to wrap up here. But a reminder from Joyce, just wanted to clarify the Fundamentals of Care framework, is the author is Kitson.
Yes, that's right. Kitson has the Fundamentals of Care framework. So based, her central core is on relational care, and then she talks about those, and I just love that language about fundamentals of care.
Exactly.
Yeah.
And just a reminder that CASN also has a set of entry to practice competencies around gerontological care.
Yes, thank you. Yes. And I think we need to use those.
That's such an excellent presentation. It's been a great past hour, and really value the engagement of our participants and their questions and comments. I certainly really appreciate how you framed the need to look at functional loss as part of patient safety. I think that will get us a long way, because I think there's a lot of acceptance of looking at patient safety indicators and initiatives, and that might be a great way to incorporate it.
Right.
And so, again, thank you so much for your presentation, and to all the participants. I just wanted to note that the session is being recorded and will be available on CASN's YouTube channel and circulated to you in the coming days. Please feel free to share the link within your networks. Thanks again to everyone, and CASN certainly hopes you'll consider attending future Lunch and Learn sessions this winter and spring. Please visit casn.ca for further information. So thanks again to everyone, and have a wonderful day.
Thank you.